All right. I guess if you guys can, if you're watching this video right now, it means I stuck with the first take and I'm not redoing it. It is midnight, and I decided to do this little presentation. It's a series I'm going to do called Chief Complaint. Um, and it's working up the main complaints that people have when they come into the emergency room that have to be evaluated. Basically, whenever you come to the emergency room, you may think it's nothing, but we have to look at it from a life or death point of view. Even though we may think it's nothing and know it's nothing, with the way medicine is today, we have to worry about getting sued, and we don't want you to die either way. So, might as well start off with the most easy one, most serious one, chest pain. Um, and we're gonna kind of go through worst case scenario to lowest suspicion, which would be young, teenage, healthy male, female coming in with chest pain, and then older female coming in with nausea, vomiting, chest pain, male coming in crushing chest pain, and then the differential diagnosis of what those actually could be. Um, so we'll start off. I also have my phone. Chief Complaint is a book that we use in the emergency room, and it's got basically everything written out for you. So if you forget how to work up these easy cases, and the reason I say they're easy is because they're drilled into you so much before you see one that you know what to do. But there's a book that tells you exactly what to do. It's called Chief Complaint. It's free on the App Store. It costs you $15 if you buy it in person. So basically, when you come in with chest pain, we have what we call a differential diagnosis. If you're a fan of House, you know that he has a very broad and crazy differential diagnosis, but what we are always told to think horses, not zebras. So if you hear hoof steps, you think it's a horse coming, not a zebra, because how often do you see a zebra? But that doesn't mean I've seen way more zebras in my day than I ever thought I would. I'm just weird like that, I guess. So when it comes to chest pain, the worst things that we think of are acute MI, which is either a STEMI or non-STEMI, and STEMI is just the way the EKG looks with the chest pain. So if it has an ST elevation, then it's called a STEMI. If it's no real not an elevation on the EKG, but you have a positive troponin, then it's an NSTEMI. And then you have unstable angina, which is like chest pain at rest that's alleviated, or chest pain with exertion that's alleviated with rest and nitroglycerin. Other things that could be is aortic dissection. This is when the main blood vessel coming off the heart that feeds your whole body is ripping in half. Most times you see this with acute blunt force trauma, with acute deceleration, so car accidents. You hit the steering wheel, you slam into the steering wheel, everything inside you slams into your chest, and that can tear your aorta. I've seen maybe 2 or 3 of these. There's a typical picture that they show of a chest x-ray. We'll get a chest x-ray in trauma. If you get this chest x-ray, you pretty much know it's bad, because this person should be going to CT anyway for trauma, but it's the chest. You normally see a black chest with a white heart, but where this heart is normally narrow up here, it's really wide, and so you can see the ripping of the chest. So other times that you would see this and not be car accident or trauma, any fall, any trauma, you could have this. But then any chest pain with where it's like tearing, very abrupt onset nature, and it radiates to the back, so you feel like it's a back pain, low abdominal pain, because your aorta goes from the top part of your circulatory system all the way down to your pretty much pelvic area. So you can have an abdominal aortic aneurysm that dissects, and then you could have a type A or type 1 acute aortic dissection. They can also show up on EKG. So there's some EKG changes that you guys don't need to know about, but if you see those, it can be evident of aortic dissection that's is presenting as a posterior MI with right coronary artery involvement, but it's actually the aorta ripping and blocking off the coronary artery, causing you to have chest pain, not only with the ripping of the aorta, but also because of myocardial infarction. Another thing that can kill you is acute pulmonary embolism. This is a blood clot, usually from the lower extremities, that goes to the lungs. The lungs are a filter from the right side of your body to the left side, or your venous circulation to your arterial, and your lungs filter that. If the blood clot is big enough and it blocks the lungs completely, you can die. Most common thing people say is, I'm going to die, and they are dead serious, and they usually do die, and it usually turns out to be a pulmonary embolism. So when people get hypoxic and they don't get oxygen, they know they're going to die, and there's not much you can do if it's a saddle embolism. Hopefully you have a good CT surgeon or interventional radiologist can go get that out. But if it's a saddle embolism, you know, not much you can do. Pneumothorax, not really that big of a deal unless it's a tension pneumo, which means the air keeps increasing inside your chest, nowhere to go, it squeezes your heart to death. But spontaneous pneumothorax or a trauma pneumothorax, you can put a chest tube in. You can diagnose that with X-ray or even better, ultrasound. Other things would be GERD, Borehave esophagus. So if you have an alcoholic that throws up a lot, they have a chance of ripping their esophagus. That can be bad if it's a transmural tear all the way through the lining of the esophagus and starts leaking into the chest cavity or mediastinum. You can have a pneumonia. You can have, anything that causes you to get sick. You can have chest pain, but we want to go from bad to worse. So this is what, even though you're like, maybe I should get checked out, this is what your doctor's thinking of right here, even if you may not think it's a big deal. They have to think it's a big deal. Okay, so what do you expect when you arrive in the emergency department? You're going to get an EKG right away. You're going to get a chest x-ray. You're going to get labs drawn, which are going to check your troponin levels to see if you have any heart enzymes leaking out. Possibly a CT scan if we're going to look for a pulmonary embolism, or aortic dissection will show up on that. Ultrasound for maybe pneumothorax. D-dimer, looking for blood clots. So a D-dimer is what's formed when you have a blood clot and you start breaking that blood clot down. You get a D-dimer. It's a tricky test because if you order it willy-nilly and somebody shows up positive, then you're pretty much screwed. You fucked yourself because you have to follow it up, even if it's a really young person, not on any birth control, no reason to have a blood clot, and you get a positive D-dimer and you don't follow it up, it's not good. If they have leg swelling, you'll get an ultrasound of their legs. If they're having chest pain, they could be anemic, If they're not having enough red blood cells, they could be causing that having chest pain. Basic chemistries and urine pregnancy if you have a female of reproductive age. So I had a hospital that said 7 to 70, which was always a weird conversation to have with parents. So you'll get the EKG coming in the door, and then the doctor on call or the physician on the department, whether it's one or a bunch, they're going to pull your chart. They're going to know you're coming in with chest pain, and they're going to do what we call a heart score and a heart pathway on you real fast. And this basically tells us, we always use clinical, our own decision making. This gives us a rough, if we're kind of like iffy about something, whether you can go home right away or you need to stay. And your LLS score, which is this bottom left here, your looks like shit score, if it's positive, you're always going to stay. If your hunch is this person's sick, if they look sick but everything comes back negative, you're not going to send them home. So clinical decision making trumps everything. This is just a risk factor for somebody that may or may not, and you're not sure. What this does is determines if you're going to have a major acute cardiac event within a certain amount of time, like a month, or I can't remember what it is. So it takes into fact the history. Does this person seem like they're having a heart attack? And depending on how severe it is, you get 1 to 2 points. Based off history alone, if they come in and it's an older guy, kind of potbelly, either from alcohol or diabetes with high triglycerides, and he's coming with chest pain, you're going to stay. Even if troponins are negative and EKG is normal, I just don't feel comfortable sending you home. I don't have to see your A1C to know you're a diabetic, or if you're healthy or not. I can just look at your body and tell. You may not feel bad, but it doesn't mean your heart's not suffering. But your EKG, if it's normal, you get 0 points. If there's some changes, but they're not repolarization changes, the ST segment, then you get a 1. And if there's significant depression or elevation, you get a 2. If you have significant elevation or depression, you're going to cath lab, and this doesn't matter anyway. It doesn't like the rest of it you just throw out and call cardiology. Your age, so the older you are, the higher risk factor, the number of risk factors you have, and then your troponins. So EKG troponins trump all too. So say if you feel good, but my husband made me come in, but you have EKG changes or you have a positive troponin, you're staying. I mean, those are evidence. There's nothing else. So they're so specific for heart that it couldn't be anything else. But so if you had a 0 to 3 on the heart score, you have at the highest a 1.7% chance of a major cardiac event. So not very high. It goes up to 16% with 4 to 6. But if you had 4 to 6, you're staying in my book. And then anything higher than that, it's a 50 to 60% chance, and you're probably having a heart attack at that time. I don't think I've seen it. Well, I've seen a troponin of 35 and an EKG change, so they would have had a 4. Probably would have had a history. So 6, yeah. I mean, I just saw the troponin on this guy. I was 35. I was like, they're having a huge myocardial infarction. And it was weird is they had a really weird presentation. They had Welland's waves for ST segment changes, but blah 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 blah. Here's kind of the heart pathway, a visual of it. So you get your heart score, which is that what we just calculated, and if they're low risk, young, I drank Red Bull, I have chest pain. Even if they did cocaine, I might not keep them because they're probably having angina. They're having chest pain from their coronary arteries clamping down. But usually you give them a benzodiazepine, so Xanax or Klonopin, and that should stop the sympathetic drive. You're not supposed to give beta blockers because they worry about coronary vasospasm, but I don't think it's enough to cause it. And they have beta blockers that are alpha blockers too, so like Labetalol, I think, or Carvedilol could also do that, but you'd be hard pressed to find somebody that let you do it unless you're an attending. If you're a resident, then I wouldn't even try it. To look like a cowboy or something, you're gonna get busted for it. If the patient they don't feel comfortable or you don't feel comfortable, but there's not full blown heart attack, then you can put them for observation. That means they're more EKGs are going to be drawn. They're in a hospital setting. They're going to be seen by cardiology, and cardiology can do a stress test if they want to. Most likely they will. Or if they don't have follow-up. Say it's not that concerning, but you're a little bit suspicious and they don't have a primary care doctor, you're going to keep them overnight for observation and see cardiology. And if they're high risk, they're going to either get PCI, which is cath lab percutaneous intervention, or CABG, which is coronary artery bypass graft. Or if you're in a primitive area, you could get TPA or streptokinase, which is a clot buster, which is no longer accepted. But when they first came out with cath lab, no one was wanting to go to cath lab, and they were giving clot busters to everybody with heart attacks. So if you watch old episodes of ER, there's an episode where they're like against cath lab, and it's so funny now that's just somebody comes in with a STEMI at cath lab. Like, we had a door to balloon time, which means when the patient enters the door to when the balloon is inflated in their vessel, I think it was 12 minutes back in Missouri. So the cardiologists like to have their little competitions. So one thing people ask is, when I come to the ER, why does my doctor spend so little time with me, especially when I'm presenting with a deadly condition? We kind of went over this. So when you come in, the triage nurses and stuff are getting your EKGs and blood drawn. The doctor knows you're coming in, and we have this kind of set thing that we're looking at. We're looking at you. Are you sweating? Are you conscious? Do you have a heartbeat? Is your heartbeat fast? We're going to ask you. So things to consider is, when did this start? Where is it located? Is it right behind the chest? Is it to the left side? Is it to the right side? Is it in the back? Is it in the stomach? If you're a woman, it can be anywhere and you're having a heart attack, honestly. It doesn't have to be chest pain. How long has it been going on? What is the type of pain? Is it sharp? Is it stabbing? Is it burning? Is it squeezing, crushing? All those matter. Like aortic dissection is a tearing pain. Pneumothorax is or a sharp pain associated with cough or something. Aortic dissection or pulmonary embolism I feel like is always like more like a sharp pain, lower lungs. Is there anything that makes it better or worse? So aggravating or relieving factors. What makes it better? What makes it worse? It's worse with exercise and better with rest. It's better with nitroglycerin, and you have more of that angina problem. Does it go anywhere? So you always hear radiates to my jaw or down my right arm. Left arm. I forgot. Yeah, it should be left arm, whatever. Left arm. And the reason for that is because all your abdominal and thoracic organs share one nerve. That's the vagus nerve. It's a cranial nerve. And your brain really doesn't have, we haven't specialized our brain. We don't want to feel our heart. God, I hate looking at my heart beating, or hearing it beat, or listening to it. So we tune that out. But that all travels along the same nerve. So you have radiation to the right side of your arm, usually up into your neck. The vagus nerve follows the carotid arteries up to the brain. And timing. Did this happen in the mornings? Have you had this before? What does it usually happen? Is there a rhyme or reason to this? I want to listen to your history. Do you have a history that's concerning for cardiac arrest, or past medical history? Do you have diabetes? Do you have high triglycerides? Do you have family history of early cardiac death? So once you hit age 65, 70, you are your family history. you don't have one anymore. Like, you are the new family history. But if you're, 40 years old and your dad died at age 50, then that's high risk. Um, if you're on any medications, if you're on drugs, if you're a smoker, cocaine, any stimulants, um, birth controls are clotting things, so you can have increase that. If you're a child, so this is where children, you have to worry, and they usually don't give you a warning, they just drop in front of you while playing sports. But there's a condition called hypertrophic obstructive cardiomyopathy, which is never diagnosed until the child collapses, except I think now they're almost making it mandatory for children to get an EKG before they start any sport, which I think is good. It's a cheap, non-invasive test, and that can show hyper or high voltage, which shows increased muscle mass of the heart. Basically, the heart gets really big, and the left ventricle pushes in on itself and blocks the output. So when it starts beating fast, it blocks the output of blood to the brain, and you collapse, and the heart starts shaking, and usually they die. They go into an arrhythmia, nobody knows what's going on, and they die of cardiac arrest. And it's very unfortunate because how are you supposed to? Why is a child supposed to get an EKG? How are you supposed to know about this? There was a famous basketball player that collapsed on the court and passed away. Other things that it could affect, Brugada syndrome is a repolarization issue of the heart that usually doesn't go diagnosed until you catch it happening. Even if you have it, it has to be kind of happening for you to see it. It's not like a fingerprint, it's always there. Family history of Brugada syndrome. Wolf Parkinson White, you have an increased heart rate. So those are some things that genetically can affect your heart, but usually it's age and risk factors that kind of go along with that. And from within walking in, we were taught once we walk in the door, we should know within like a minute or so if you're going to stay or you're going to go. So we're going to get a disposition on you probably within that time. We're not going to tell you what it is. But I said, if you're older in age, you're probably going to stay for observation. If you're, in your 30s, healthy, look healthy, not just say I'm healthy, but like you look healthy objectively, and you're going to be shamed by your doctors, which you should be to save your life. I hate getting my BMI because I didn't think I was overweight or obese, and then I did that, and I said it was, so screw that. But so either we're going to do the heart score on you, we're going to look at you and judge based off your story and your test results. So one always trumps the other. If the test results come back negative, but your story and you look like crap is strong, then you're staying. If you look great and feel great, but your tests are really wonky, you're going to stay. We're going to give you medication for the pain. Used to be the gold standard was Mona, which was morphine, oxygen, aspirin, and nitroglycerin. Morphine is no longer thought to reduce preload. The dangers of giving nitroglycerin is if they're having a right-sided heart attack and you dilate their blood vessels, they're right heart dependent, and you just drained all their blood from the right heart, and you'll throw them into cardiac arrest. Not something you should worry about in the ER because we can fix that right away. But I always kind of wonder, like, should I give nitro at home or somewhere? Because you can't treat a posterior MI there. You're also gonna get a chest X-ray, and then we're gonna look for the other things. Is this possibly aortic dissection? Were you in a car accident? Do you have Marfan syndrome? If you have it, you know you have it. If you don't, then don't need to worry about it. Do you have any other connective tissue disorders? Do you have a pulmonary embolism? Do you have history of blood clots? Do you have cancer? Have you had surgery or been immobilized recently? Have you just got off a plane or a long train, car ride? History of blood clots. Have you had any leg swelling? Is your heart rate? Your heart rate's the first to respond to everything. It's going to go up or down for the littlest things. So if a heart rate over 100, it's not usual. Oxygen saturation less than 95% on room air. That is if you don't have obstructive pulmonary disease. If you're emphysemic or COPD, you're probably going to have a less than 95. I hope you do, because if you're killing your oxygen drive, then you're not doing that well. If you cough up blood, probably not a good thing. History of blood clots or pulmonary embolism, and you're on birth control. Those are all risk factors. So yes to any one of those. I can't rule it out with the history. I'd have to do tests. That's where they're going to order a D-dimer on really low pretest probability, but PE still suspected, then you order the D-dimer. If it's positive, then go ahead and work it up. If it's negative, then you can feel comfortable about sending them home. If you think it's PE, no matter what, don't order the D dimer. I mean, I wouldn't, because if it's negative, you're still gonna carry on with your CT scan. If it's positive, you didn't learn anything new. When don't you order it is when you know it's not a PE, but you just shotgun all your tests and you order a D dimer and it comes back positive for some reason, whether they had like an injury and had some clotting somewhere, and now you're screwed working this person up because you can't justify sending them home when they come in with chest pain, shortness of breath, and a positive D dimer. So those are why all the tests are being ordered. The reason it takes so long is because they have to wait 3 hours for the troponin, the second set. You get the first set upon arrival. If you've waited all day and you've had chest pain all day and you come in and you have a 0 troponin, depending on your story and your history and stuff, I may not order a second one because you've been having it 8 hours and troponins last for 7 days. And especially if you don't have any other cardiac like CKMB or anything elevated, then there's no need to work you up. But if you just had acute onset, I had a dinner, I came straight here, it's been 15 minutes, then you're gonna have to wait 3 hours for both sets to be negative before we can send you on, because they take a while to elevate. They do have super sensitive troponins now, which I think one set can do, but you're always worried about your ass, so I don't care that you're inconvenienced an extra hour, right? I'm stuck there. If you feel like the decision making is wrong, like there's something wrong with you because you know your body, speak up. That is not to say if a doctor is being pleasant with you and has worked with you and says you're okay and you're just scared that you need to stay, because that's not necessary. But if you were like really feel like something's wrong, then it's your body and you have every right to say. I'll show you this. Let's see. I think it's no, that's me. Oh, there we are. Oh, I have to broadcast it. So I'm trying. There we go. Well, this is basically just showing you the app that you can use. And like I said, it's free on the App Store, but if you buy the book and have a hard copy, then it will cost you $15. I like having hard copies because I'm just like that, but the app is really it's free, so you can use it. You don't have to be a doctor to get it. You don't have to hide behind that prestige. So you just go to the chest pain logarithm if you're just curious, if you're interested in medicine and you want to learn about it. That just kind of shows you the workup right there from all the causes that they're going to rule out, your treatment that you could expect, and even your heart score. I believe it has on there, so you could even do that at home. It's a good thing to know. So if you're ever wondering, should I go to the ER? I always say go because you have to, because you haven't been taught to make those decisions. But you can understand what you should expect once you go. So like history, chest pain, radiation to arm or jaw, risk factors for coronary artery disease. I can't make you have the same pain. It's not worse when you breathe and you have nausea, vomiting, or you're sweating really bad, then you're positive for a STEMI. I mean, I'm gonna even send you to cath lab with that. So you can just kind of go through here. The great thing that we're going to go through in more of these videos is it's not just chest pain, but it's shortness of breath. It is tummy pain. It is bladder, urination. It's got everything. I don't know why I keep clicking those. Infectious disease, neurology, pediatrics, OB-GYN, trauma, eye problems. So it's got everything, and it tells you exactly what to do. You got your calculators here for your blood clots and heart score. It's got, what else does it have? Oh, it's got your drugs too. Let's tell you what drugs to give. How much? Yeah, kind of. Yeah, I guess so. I wouldn't trust this for my medications, but it's really fun. And it's all evidence based. I mean, this is all you're gonna learn in school, all you're gonna learn in Up to Date. So check it out if you're interested in that type of thing. If not, then don't worry about it because you don't need to if you don't find it interesting. With that said, I want to watch this recording and then decide if I want to upload this or not. I can't really see myself doing it again. Where is that camera? I don't know. I don't even know what I'm doing. Alright, whatever. Okay. So, hope you guys learned something. If you have any questions, and I do post this, then send them to me. Otherwise, go. Bye.